Wishing everyone a happy Mother's Day today. So to all those mothers out there listening, thank you very much for everything that you do. Now, today we're going to be covering EEG and BIS. And I'm hopeful that the first half, which is just covering the EEG, will be a summary. And then the BIS, we're going to introduce some concepts which the examiner talked about and really sort of build on those ideas. There are built in a lot of complexity, like a lot of formulas. I don't think you'll be expected to learn the formulas, but you will be probably asked to sort of give an overview of the idea of how BIS and entropy is actually created. So I'll show you some sort of keywords to use in your answer. Now, with the breakdown of the short answer question, as always, we're going to review the examiner's report. And then after that, I'll sort of show you the literature that I used, present the key concepts, answer any questions, and then I'll show you an answer structure, and then we'll all write an answer to time. This is the 2017 B4 question, which is describe the generation and features of a normal awake EEG. Briefly discuss the processing performed by quantitative EEG monitors, such as BIS or entropy, to produce a single number from the EEG. This is the examiner's report. So again, I've highlighted all the statements in green, which we need to include in our answer, and the ones in red are the ones to avoid. In the first part of the question, candidates' answers should include that EEG is the summation of excitatory and inhibitory potentials of the cortical pyramid cells. This line is straight from Power and Cam. So I know that this question is based on chapter 11 in Power and Cam. EEG is typically small with a low voltage in the order of 0 to 200 microvolts. The EEG is characterized by its frequency and amplitude of the waveform. A few candidates were able to recall the 4 main frequency bands. Can I just pause here? And this is really interesting because if you read the original question, I'll just quickly go back to the original question. The first part says, describe the generation and features of a normal awake EEG. But yet in the examiner's report, it certainly has components where we are actually going beyond what the awake EEG is. So I think we just need to make a point of that even though they ask for the awake EEG, we probably need to include the other bands, which include sort of the asleep EEG. So the 4 main frequency bands are less than 4 hertz, or the delta waves, 4 to 8 hertz, the theta waves, 8 to 13 hertz, alpha waves, and more than 13, the beta waves. But many of the figures were incorrectly cited. It should be noted that normal EEG in an awake individual is asynchronous of low voltage and high frequency. The majority of candidates misinterpreted the second part of the question and provided answers to highlight the utility of the processed EEG. And this would be more a part 2 or final exam answer discussing the use of BIS or entropy. The question clearly asks for the methods that convert complex EEG waveform into a single number. This often includes multiple techniques such as time domain analysis. So we just make a point here. This is a really important concept, time domain analysis. And they've given you an example such as burst suppression and frequency analysis. And the examples here are beta ratio, spectral edge frequency, and others like bicoherence or entropy. What I'll do is I'll quickly go through these concepts because the way that it's being presented at the moment, it sounds as if like beta ratio and spectral edge frequency are all part of the BIS index, but I'll show you why it's not quite that way. And then also ideas like bicoherence or entropy sound like different entities. So I think it's really important to understand what these concepts are in order to be able to reproduce them in a coherent way or rather in a logical way in our answer. Now, a summary of the examiner's report. So we need a description of the EEG. And really, I think this is a line that we need to recall, and that it is the summation of excitatory and inhibitory potentials of the cortical pyramid cells. And then the amplitude is 0 to 200 microvolts with 4 main frequency bands. So delta waves are less than 4 hertz, theta waves 4 to 8 hertz, alpha waves 8 to 13 hertz, and beta waves more than 13, and a description that they are asynchronous, low voltage, and high frequency. If you can see the pattern here, and look, I don't think you need to be perfect with these ranges. Like, you can be 1 or 2 hertz out and it would be fine. And so that you can see that there's a pattern of less than 4 to 8, and you can even go 8 to 12. Okay, 8 to 12 and more than 12 hertz. So that if you're struggling to remember this, I would just use that pattern. Less than 4 hertz is delta, 4 to 8 is theta, 8 to 12 is alpha, and more than 12 is beta. I think that's more than acceptable. Now, the second part of the question is that we need to discuss the algorithms used in EEG. And these would include the idea of time domain analysis, frequency analysis, biocoherence, and entropy. And I'll sort of group them in a more coherent way than what has been laid out in the summary of the examiner's report. This is the literature that I've used. For the EEG, so for the first part of the question, I've used PowerCam, chapter 11, consciousness, EEG, sleep, and emotions. I've added a little bit from Miller's chapter 40, monitoring the state of the brain. Now, this third article here is very detailed, but it contains probably the most relevant information for how BIS is produced. So I think have a look at it, but don't worry about looking at too much into detail. I've summarized the main points of this article in this presentation. But I think if you want to have sort of a complete overview of the concepts, do go and have a read of this article. It is quite in depth. Okay, so this is by Rampil, a primer for EEG signal processing in anesthesia, and published in 1998. For the entropy, we know that entropy, the algorithm has been published. So this is a description of the entropy algorithm as applied in the Datex-O-meter entropy module, and that was published in 2004. And there's actually a nice summary. So a nice little booklet that's provided by Medtronic, who create the BIS or Aspect Medical, and it's titled Monitoring Consciousness Using the Bispectral Index Brain Monitoring System. And I think it really provides a very nice overview of the clinical relevance of using BIS, as well as really provides a really nice summary of the potential of interactions with BIS, which I've actually included in the end of this slide here. So let's start off with the summary of Power and Chem in chapter 11. And this really is just talking about EEG. And the way that it describes is that it records spontaneous electrical activity of the brain. And the current is the summation of both excitatory and inhibitory post-synaptic potentials of pyramidal cells. The rhythm is controlled by the thalamus, with inputs from the reticular activating system causing desynchronization. So remember that the reticular activating system is really important in terms of wakefulness or consciousness, and they are located in the brainstem. And what they do is inputs here will, it will deliver signals to the thalamus, and inputs from the reticular activating system will be relayed off to the cortex. And that is what creates the excitatory and inhibitory postsynaptic potentials of the pyramidal cells. The potentials that are measured are between 0 to 200 microvolts. This slide here, I think, is really important for you guys to memorize and recall. You want to be able to reproduce a definition of EEG, both in the written and verbal form, okay, for this exam. So understand that it is electrical activity and that it is both the summation of excitatory and inhibitory post-synaptic potentials of the pyramidal cells. Now, quite often they talked about sort of 4 main spectrums, but there is a 5th spectrum that I've included here. And I think more and more you will hear it being talked about, which is the gamma waves. The reason why I've included it here is because, you know, doing a lot of vivas, I do get to hear what trainees are sort of presenting. And it seems that, you know, they do like to include the gamma waves in their answer. And I believe Dr. Catherine Davies, who also did the CNS Tute a couple of months ago, she also talked about the gamma waves here. So just going through it with the frequency spectrum, you've got the delta waves, which are less than 4 hertz, and I've got the amplitude here. So it's between 100 to 200 microvolts, and they are present in stage 3-4 sleep. I've got the delta waves, which are 4 to 7 hertz, and again, 50 to 100 microvolts, and they are present in stage 1 sleep, general anesthesia, or meditative states. And you can also see them in stage 2 sleep, but with sleep spindles and K complexes. You've got the alpha waves, which are 7 to 13 hertz, and 50 to, and they're again 50 to 100 microvolts. They are present in awake, but with your eyes closed. And then you've got your beta waves, which are 13 to 30 hertz. These are irregular, asynchronous, and the amplitude is less than 50 volts. And they are present when you have visual stimulation or mental activity, and as well as REM sleep. And then after that, you've got the gamma waves. The gamma waves are a little bit controversial because they overlap with EMG frequencies. And so that one of the thoughts is that they don't actually exist, and that they actually represent muscular function, okay? But they are still being talked about, and you can actually find references regarding gamma waves and what they actually represent. And more often than not, they are a sort of a higher level of activity than what you see in the beta waves. So they represent sort of large scale brain network activity. As you can see, I don't know whether you've noticed here, but I've got different, I've got a different scale here. So I've got less than 4, 4 to 7, 7 to 13, 13 to 30. Whereas if you see the ones from the examiners here, sorry, you've got less than 4, 4 to 8, 8 to 13, more than 13. So you're about 1 hertz off. And as I said, I don't think you need to be specific. I've actually seen a lot of texts which are out by about 1 or 2 hertz. So I think that if you're within sort of the ballpark, within the range, it should be fine. Now, with the depth of anesthesia, how do we measure depth of anesthesia? And that's a question that you might get during a viva. And if you do get it during the viva, the way to sort of think about this is that they're both clinical as well as ways that you can measure it objectively. So clinical signals or signs could be things like hypertension, tachycardia, movement, or autonomic responses. And measurements would include things like spectral edge frequency, or the use of bispectral index or BIS, and or entropy. Now, remember that the examiner in the exams report brought up the idea of spectral edge frequency. And spectral edge frequency, or you'll often see the term used as SEF 95, or you can even see SEF 50, but they represent the frequency below which 95%, so SEF 95 is 95% of the total power of a given signal are located. So if you had SEF 50, it would be the frequency below which 50% of the total power of a given signal are located. And we'll talk about what power is in the next couple of slides. Now, what this means is that spectral edge frequency has been used previously as a way to measure depth of anesthesia. It's not actually part of BIS or Entropy, but it is a method. It is a method of frequency domain analysis or frequency domain assessment to actually determine how asleep or how anesthetized a patient is. The ones we're going to focus on today is going to be BIS, and then we're also going to touch on Entropy as well. And these are validated parameters composed of complex subparameters. And we're going to delve deeper into what these subparameters are. This is the breakdown of how the BIS index is created. So you've got the EEG signal, which is then digitized, filtered. And if I could just show you the next slide, you've really got two things that happen to it. You've got this pathway here. So you've got this idea of what's called suppression detection. And then after that, you've got this other pathway where you've got fast Fourier transformation. Now, knowing this, we can sort of determine that the two things that are going to happen. So one is it's going to try to detect what we call burst suppression, and that's called time domain assessment. With the second, so with the one that's highlighted in blue, where we've got the fast Fourier transformation, this is called the frequency domain assessment. And I'll show you those ideas in the next slide. So we're going to start off with time domain assessment and what that means. So remember, if I go back to the next slide, time domain assessment is the one that's highlighted in yellow. That includes suppression detection. What does time domain assessment mean? Well, it examines how EEG voltages changes over time. And what it does is it looks for patterns. And that's essentially it. And I will go through a little bit more in detail what it actually does. Okay, but for this time, for this moment here, just understand this concept. Time domain assessment examines how EEG voltages changes over time. Then you've got this idea of frequency domain assessment, and this examines signal activity, and they break down signal activity as amplitude and phases as a function of frequency. So conceptually, what it does is, if I've just got this on this graph here, you've got frequency on the x-axis, and what you have is you've got these spikes. Okay, so for a given frequency, what it does is it plots the signal activity. So the first one here is magnitude or amplitude. And what it's saying is that at this frequency here, the amplitude of those waves are of this strength or of this power. Okay. And similar concept here is that at this frequency here, so at this same sort of frequency, we're looking at the phases. What phase of the signal? Remember that with EEG signals, they come in sine waves. So they go up and they go down and they go up and they go down. So what it does is it looks at that certain frequency, and it looks at the phase at which it's in, and then it plots it as a power. Okay, so that's what it means in terms of examining the signal activity as a function of frequency. There are complex formulas related to this, but this is just a general overview of how it starts off with. Okay, so remember that if anyone sort of asks what this signal activity is on the EEG, we're looking at amplitude, so how high or how low it goes, and then the phases. And what we're going to concentrate on now is the time domain, which is suppression detection, and what that means. With time domain assessment, it detects deep anesthesia. So what it's looking for is burst suppression. And we know that when we think about depth of anesthesia, what happens after delta waves is that you get burst suppression prior to the isoelectric EEG. And the way to detect burst suppression, there are a couple of algorithms out there. So the two that they use in BIS are burst suppression ratio and quasi. And these are just algorithms to detect burst suppression that detects depth of anesthesia. And so if we go back to this diagram here, you can see that after it's being filtered, you've got the time domain assessment, which is burst suppression detection, which uses the two algorithms, BSR, which is burst suppression ratio, and quasi. Now, let's move on to sort of frequency domain assessment and what that means. With frequency domain assessment, what you need to do first is that you actually need to transform those waves and break them down into their harmonics. And then what you do next is you present them as either a power spectrum or power spectral density. So they're both the same things. And they were the graphs that I showed you previously. So let me just sort of go back here. These ones here, these would be called power spectrum or power spectral density. So these are very, very basic ideas in terms of how they are presented. Okay. Now, the second thing which they do is called bispectrum. And bispectrum is a third order statistic. So power spectrum is a second order statistic. And what I mean is, when we talk about first order statistic, we're talking about things like mean, median, mode. And what they do next is that with this analysis and the way that they present the power spectrum or power spectral density, you're looking at a second order statistic. And then a third order statistic is bispectrum, which is actually is another form of sort of describing the relationship. So what it does, it tries to describe the correlation. And I'll sort of I'll go through that in a slide in a second. Let's touch on first with power spectrum, which is the second order statistic. So power spectrum describes the distribution of signal activity. And remember that the signal activity is the amplitude and phases as a function of frequency. And this is analyzed by the beta ratio. The bispectrum, which is a third order statistic, this describes the correlation of signal activity. So what it does is it looks at the amplitude versus the phases. In other words, that what it wants to find out is that at certain phases, do you tend to get high amplitudes or low amplitudes associated with certain phases of the frequency? And then it describes that as a function of that frequency. So that's what bispectrum does. And then you hear the word bicoherence. And bicoherence is the squared normalized version of bispectrum. And this is analyzed by what's called sync slow or sync fast slow. As you can see, the concepts here, you might be going, this is quite in depth already. I can tell you that it can go even deeper than this. But I think it is important to have a sort of a broad understanding of the ideas. I don't think you need to, how would I say, explain it in such depth. But I do think you need to have an appreciation that that these are parameters with mathematical constructs behind them in order to try to describe the relationships between a number and correlate it within depth of anesthesia. And that these are what all these sort of ideas that I'm presenting are actually talking about. And so that all the parts in the blue that is part of the frequency domain analysis. Okay, so we've got fast Fourier transformation, and after fast Fourier transformation, it presents that as a power spectrum or power spectral density, and that's a second order statistic, and that looks at the distribution. Okay, so it focuses on the distribution, and what it does is it's analyzed via the beta ratio. And then after that, you've got the bispectrum, which then looks at the correlation. And that is analyzed by what's called sync slow or sync fast slow. And this is just a summary of what they do. So the beta ratio detects light sedation. You don't need to know this formula, but what it does is it's the log ratio of the power at 2 frequency bands. So it's the log of 30 to 40 hertz divided by the power at 11 to 20 hertz. When you look at the sync fast slow or sync slow, this detects light to moderate sedation. And again, it's the log ratio of the sum of the bispectrum at 2 frequency bands. So what we're doing is we're logging the bispectrum at 0.5 to 47 hertz divided by the bispectrum at 40 to 47 hertz. This table here describes or summarizes the ideas that I've just talked about. So time domain, remember that time domain assessment is looking at how voltages change over time. And specifically, we're looking at burst suppression ratio, or sorry, the idea of detecting burst suppression. And we do this with the 2 algorithms, so burst suppression ratio and quasi suppression. And then after that, you've got the idea of frequency domain assessment. And the bispectral domain is actually a function of frequency domain assessment, okay? So remember that frequency domain assessment with power spectral analysis looks at the distribution, and that's analyzed by the beta ratio. The bispectral looks at the correlation, and that is looking at sync fast slow. Sorry, that's using sync fast slow. Now, entropy. So the nice thing about this is that once you sort of understand the way that BIS works, entropy actually uses the same ideas as well. So entropy means that it measures the degree of disorder in a system. And again, it uses both time domain assessment as well as frequency domain assessment. So time domain assessment, just as a reminder, explains how EEG voltages changes over time, specifically detecting burst suppression. And frequency domain assessment examines the signal activity as a function of frequency, and what the authors have called spectral entropy. Now, what do they mean by spectral entropy? So spectral entropy describes the degree of disorder in the power spectrum. And remember from our previous slides, when I talk about power spectrum and power spectral density, so they're the same thing. Remember that this is describing the distribution of signal activity as a function of frequency. And it's derived from fast Fourier transformation, which breaks down waves into their harmonics. And essentially, that's what spectral entropy is. It analyzes the waves after they've been broken down by fast Fourier transformation. And then what it does is once you've got the power spectrum published, or explained through its algorithms, then it uses its formulas to calculate and report 2 numbers. And the 2 numbers that they report are state entropy and response entropy. And I've got the diagram here in terms of to show you what they sort of represent. So state entropy is from about 0.8 to 32 hertz. So about, 0.8 to 32 hertz. And they encompass all the waveforms in EEG. And the response entropy, it varies from 0.8 to 47 hertz. So it includes EEG and EMG. And just to summarize, with state entropy, it tracks changes in the frequency range of 0.8 to 32 hertz. So it's EEG dominant. And the number that it produces ranges from 0 to 91. The time window, which it sort of captures, it's sort of between 15 to 60 seconds. And the reason for that is that it's a stable number, so that if there are transient fluctuations, they are removed from the data. And the reason for that is that it wants to represent the stable effects of hypnotics. So if you ever use entropy, state entropy is the dominant number that represents the effects of hypnotics. Now, response entropy, that tracks the changes in the frequency band between 0.8 to 47 hertz. So that includes both EEG and EMG. The number it produces is 0 to 100, and the time window, as you can see, is a lot faster. So remember that state entropy was 15 to 60 seconds. This one here is 2 to 15 seconds. And the reason for that is that this is the number that reacts fast to change. So that if you have any moments of sort of arousal, or perhaps that, a patient has gone from deep to light anesthesia very rapidly, response entropy is the number that's gonna change first. So response entropy rises simultaneously with muscle activation. And then after that, you'll see state entropy follow a couple of seconds later. This is an MCQ question. And I believe that the question sort of is conceptually asking you about which number would change first. And the answer to that is response entropy is the number that changes first. Now, I'm going to quickly sort of summarize the factors that influence BIS or entropy. And this is from Miller's Anesthesia. So with Miller's, they talk about 3 drugs here: ketamine, nitrous oxide, and dexmedetomidine. And what they say is that with ketamine, you get high frequency oscillations, so that your BIS number might be high, but you're actually unconscious. With nitrous oxide, there is increased amplitude of high frequency EEGs and decreased amplitude of low frequency EEGs, but the net effect is 0. So that it's a little bit controversial, a little bit ambiguous. There are a lot of studies which show that actually nitrous oxide doesn't have an effect on EEG, but there are also studies which show that they do. And I think that on the overall basis of things, I think it's safe to say that nitrous probably has little to no effect. Now with dexmedetomidine, what happens with EEG waves is that they produce slow frequency oscillations. So the point here being is that you might be conscious, but you've got a low BIS number. This is really interesting. So they talk about age in Miller's, so that adults who are sort of aged more than 60 years old are associated with lower amplitude oscillations. And funnily enough, what it does is it can be either interpreted as awake or unconscious. So it seems to be one extreme or the other. It's an interesting idea. I haven't sort of delved into it much deeper than that, other than sort of have that little paragraph in Miller's, which just says that just be cautious in older patients, and that the BIS number may not be as certain as it would in younger adults. Now, in children, what's interesting with children is that they get increased alpha wave coherence from the age of 1. And remember that if you have waves that are coherent or that have strong association, that can be sort of a pattern that the algorithm can recognize. And the way that it's being interpreted in the BIS is that it can be interpreted as sedation instead of unconsciousness. Now, what I think this sort of represents the alpha wave coherence, what they think is just the development of the brain. Okay. Now, remember that as you become more unconscious, you should be producing, theta or delta waves. And the fact that, alpha wave coherence or alpha waves are being predominated here, that's why it's being shown as sedation. And I believe that why it's sedation and not sort of awake is because of the coherence to it. Because if you're awake, it tends to be more asynchronous. Now, finally, I've just summarized, or rather taken a summary from the booklet that's produced by Medtronic to talk about some ideas in terms of possibly what can affect BIS. And you can see that the use of neuromuscular blocking agents can reduce your BIS number. And the reason for that is because it helps get rid of EMG artifact. Remember that EMG artifact can actually artificially increase your BIS. And the important fact is that during stable anesthesia without EMG artifact, neuromuscular blockade has little or no effect on BIS monitoring values. Some other ideas are that electrical mechanical artifact may occur with pacemakers, forced air warmers, surgical navigation systems, anything that a surgeon may use to operate near where you're actually monitoring your anesthesia. So endoscopic shavers and electrocautery. It's quite an extensive list. And I don't think that you need to name every single one, but I think you can give sort of one or two examples for each sort of idea. Now, other conditions. So what they are explaining here is that anything that reduces cerebral metabolism will reduce your BIS number. So things like cardiac arrest, cerebral ischemia, hypoglycemia, hypothermia, they will artificially reduce your BIS number due to the reduction in cerebral metabolism that's associated with these clinical conditions. And then we've got abnormal EEG states, things like dementia, I think epilepsy is in here as well. So that's quite interesting. And then finally, I think they've got drugs. So the drugs that they mentioned, ketamine, that's the same one that Miller's mentioned. They've also got etomidate, which is really interesting. They said that etomidate may cause drug-induced myoclonus, which may transiently increase BIS monitoring values. Halothane, they've got it listed, results in higher BIS monitoring values than isoflurane or Sevo at equipotent MAC doses. I'm not sure what the mechanism is there. Isoflurane, where you get transient paradoxical response to increased dose, has been reported. Nitrous oxide may have minimal effect on BIS, and ephedrine, but not phenylephrine, may increase BIS monitoring values. This will be my answer structure. I would have a definition of EEG. So remember that the definition of EEG is that it is the electrical activity and it's the summation of both inhibitory and excitatory post-synaptic potentials in the pyramidal cells. And then after that, I would have description of the EEG waveforms. And I would make a distinction that these are the awake EEGs. And because the examiner put it in the answer, and it may be beyond the scope of this answer, but I think given that it's mentioned, I'll also include the sleep ones as well. Okay, so those are the delta and the thetas. We're going to have a definition of BIS. And then after that, I'm going to split it off into that the features are time domain assessment and frequency domain assessment, and have those sort of keywords in there. And if I have time, I'm going to quickly mention the factors that affect BIS. All right, so we're going to do the best we can to write an answer to 10 minutes. To make sure okay. All right, so remember that, so just to go through again of your structure. So you need to have a definition of EEG, a description, and that should probably take you a page and a half to do. And then what I'm going to do is, because this is a two-part question, I'm going to answer the second part of the question on a new page, so probably on a third page, and that would involve a definition of BIS, and then after that, the features associated with BIS. So that would be time domain assessment as well as frequency domain assessment. And given how much time I have left, I'll see how much I can write in terms of factors that affect BIS. All right. Okay. So let's go, 10 minutes. Definition of EEG. So EEG measures the electrical activity in the brain and is the summation of both excitatory and inhibitory post-synaptic potentials of the pyramidal cells. Rhythm is controlled by the thalamus with inputs from the particular activating system, which represents consciousness. Creates this synchronization. EEG waveforms are described by their frequency and amplitude. Awake EEG is characterized by 1, gamma waves, so 30 to 80 hertz, irregular, less than 50 microvolts. They represent large scale brain activity, overlaps with EMG frequencies. 2, beta waves, which are 13 to 30 hertz. Again, they are irregular, less than 50 microvolts. They are awake, eyes open, also present in REM sleep. 3, alpha waves, which are 8 to 13 hertz. They are 50 to 100 microvolts. And they are awake, eyes closed. After that, you've got other EEG frequencies. So 4 theta waves. So they're 4 to 7 hertz and 50 to 100 microvolts. They represent stage 1 sleep, GA, meditative states, stage 2 sleep, but with sleep spindles, and K, complexes, 5, delta waves less than 4 hertz, and they are large amplitude at 100 to 200 microvolts, and they represent stage 3 to 4 sleep. Let's go to a new page. So this spectral index is a monitoring algorithm that combines EEG features correlated with hypnosis, where 100 equals awake, 40 to 60 equals GA, 0 equals isoelectric. This number has been validated in clinical trials. EEG features that are assessed on time domain detects deep anesthesia through the presence of first depression using the following algorithms. So BIS and quasi, and then number 2, frequency domain by fast Fourier transformation, centered as power spectrum. It's a second order statistic analyzing distribution, detects light sedation by the beta ratio, and 2 by spectrum, which is a third order statistic analyzing correlation, detects light to moderate sedation by sync plus slow. So I've only got a minute and a half, so I said this can be affected by medical devices, diabetic, pacemaker, low cerebral metabolism, cardiac
rest, hypothermia, abnormal EEG states, epilepsy, and anesthetic agents. Ketamine. All right, done. And that's it. So that's my answer here. So I've got my definition of EEG, and specifically what awake EEG is characterized by. And then the second page, I've just got the other EEG frequencies that are there. And then my third page is definition of BIS, and then the ideas of time domain and frequency domain assessment. And then just because of timing, I've just written a sort of a brief summary at the end with regards to what it can be affected by. Yeah, how did you guys go with that question there?